Well, thank you. We'll start again, and our colleague Trine-Lise Bakken from Norway is going to talk about working with inpatients with borderline personality disorders and using dialectical behaviour therapy techniques. And then I think Brian is going to add some comments at the end.
Brian is the expert here, so.
Yeah.
Okay, thank you for having the opportunity to come here and talk about our department and how we work. Yes, these are my colleagues here. It's our head psychologist and I. We have working on DBT for patients with borderline disability, borderline personality disorders for many years. And I noticed that Ken, he's not here now, has said it in his presentation that they rarely use borderline personality disorder diagnosis, but we have found it quite feasible, so I will say a little about that. Norway is a small country in population, but a large country. It's a large country. It's sparsely populated, and people mainly live in the cities and in small communities spread all over the country. We have a predominantly public health care system with some private hospitals, but they are few. And the health services are organized, I think, in most countries. It's the local services and it's the specialized services. And there we also have some regional and national services because as we have a very small population, some of the diagnostic groups, there are not so many, so we try to build up competence and care and treatment for these patients in some centers. And I would just say that regarding mental health services for people with ID, in Norway the services still are very fragmented. Unfortunately, it is the address where you live that predict if you have quality services, or you have low quality services, or you have no services if you have an ID. So we are working on it, but it's still we are still working on development of services all over the country. I work here. It's an old psychiatric hospital, more than 100 years old. It used to be the largest psychiatric hospital in Northern Europe. It was almost 2,000 patients here in the 60s. And now it's about 300 patients left. Because, and as in all other countries in Europe, most mental health services are decentralized. It's outpatient clinics, mostly. We have both inpatient and outpatient services. We have about 10 beds for the more patients with a more severe diagnosis like psychosis and major depressions and also personality disorders. The patients stay in the inpatient services from 3-4 weeks up to 6 or 9 months. And then we also have a follow-up program for about 6 months for each patient who are admitted in the inpatient services, and that is basically to train the local services in understanding of the symptoms and giving good services, really. And we are also cooperating very closely with their local doctors. And our catchment area has 2 million people, and we have 10 beds, and as you understand, that is not enough. In Norway, we have a totally of 20 beds designated for people with ID and mental health problems. In Finland, I think you have more than 250 beds.
Yes, we.
Yeah. I was so lucky to. Last year I was with 4 other colleagues in Finland and visited mental health services in Helsinki and also a center, Kehitysvamma center outside Helsinki, and that was very useful for us. And we saw how elaborated services you have here in Finland, and we felt very ashamed of our very few, inadequate services in Norway. So we have used the Finnish organization to work through our politicians to have more attention to our patients in Norway. So it's very wise to go abroad and get home some new knowledge. Next year we hope to visit Netherlands and Janeline and her colleagues. So the aim of this small project was to investigate the use of systematized inpatient treatment inspired by DBT for these patients with borderline personality disorder, BPD. The background is that we have, over a long period of years, had patients coming into our clinic who have had very complicated diagnostic issues. And in Norway, it has been, it's been an approach or thinking about patients with personality disorders that inpatient treatment is bad for them. And also that using personality disorder diagnosis is not good for people with intellectual disability. And that has been a big debate in Norway. But we have found that clinically it has been feasible for the patients to diagnose them with personality disorders when we are sure that they have personality disorders, in order to educate the outpatient services in the communities in order to give them adequate services, and learn and educate the carers in the communities that personality disorder may have a good prognosis. We know that borderline personality disorder is the one personality disorder with the best prognosis. Large international studies showed this in the general population, but there is no adequate research still for people with ID. So Norway is two small countries, and we are hoping that the international research community will come up with better data over the years. But we have seen clinical results, so that we, during the last 4 years, we have tried to build up a program for our patients with this diagnosis in a more systematic way, to see if working more systematically will give a bit better outcome for the patient. So this is a very simple project, really. Dialectic behavior therapy was developed by Marcia Linehan. She's an American psychologist. I guess she's known to most of you. She was diagnosed with schizophrenia when she was in her teens, and later on she diagnosed herself with borderline personality disorder. She is very much into Zen Buddhism, which has exception of your own status, your own symptoms, what you are yourself, and being aware of how you relate to the environment as a core factor. And she has done research, and she has built up this therapy, which has been widely used. In Norway, dialectic behavior therapy is widely used for a lot of diagnostic groups, especially in young people with all kinds of mental health problems. So in Norway, it's always also possible to be educated in this program. The manual, according to Linehan, has some core principles. First, you have to get a relationship with the patient, but I think that's the basic factor in all mental health treatment, that you have to relate to the patient, you have to build therapeutical alliances. And that is a premise for having a good clinical outcome. And acceptance of your own situation and of your symptoms and validation from the surroundings are the core principles. And Marsha Linehan is also very concerned about mindfulness, meaning that you are being aware of what's going on between yourself and other people. And then it's the skills training, learning to tolerate distress and emotions. In all kind of mental health problems, dysfunctional emotional regulation is a core problem, and for these patients with ID and borderline personality disorder, the experience of the emotions taking over all of you, I think it's maybe the main problem. And of course then it leads to suicidal behavior and also to a lot of other behavior problems, really. Working in groups and individually, and then duration, according to the Norwegian manual, should be about 1 year, but that is in outpatient groups. And Brian Barrett, who is present here today, and colleagues in Germany, they have made a manual modified for people with intellectual disability, which is very practical, I will say. I just made some bullet points here, and what differs from the manual for patients in the general population is that carers are included in the process, and that is the way we work in our department too. Each patient shall have a therapy plan. There are group sessions, and there are skills training daily, individually, and without a specially trained staff member. And I will come back to that. Using worksheets and the manual from Barrett and his colleagues is very practical. They have made worksheets that can be used, I think, for patients with both mild and moderate intellectual disability, with pictures and explaining how to cope with emotions and use their senses and many things. And the manual also include an emergency kit. What shall we do when a crisis arrives? We are working on an article to try to publish the way we work, and then we have picked up 6 patients that have been in our inpatient services during the last years. And of course, to prove that this intervention works, we have scored the patient at admission and at discharge, both on behavioral problems and on mental health problems. Then we have used the ABC, which is widely used, and also the SCL-90, which is a commonly used screening instrument for mental health problems in the general population, and that is normed for Norwegian in Norwegian language, so that's very much used in Norway. So we chose to use instruments that are widely known. And we asked some of our colleagues to write some case presentations about these 6 patients, and they have also scored these instruments. These patients, they stay in our clinic from 4 to 6 months, and for all patients coming to our clinic, the first weeks we don't start any specific treatments. We're just getting to know the patient. The individual therapist, which is usually a psychologist, they are getting to know the patient, they are doing some diagnostic work, sorting out areas for skills training, and the nursing staff, they are sorting out special interests. Because we have very good experience from using their special interests in the skills combined with the skills training. For instance, if they are very keen on bird watching, then we are using books about birds. We are going out in the woods. Our clinic is far from the city, of course, as all the psychiatric hospitals used to be. So we are going out in the woods, trying to find birds, watching birds, and then when they get emotionally aroused, we are using the books about birds, we are using pictures taken out in the woods and using these things to calm down. So we are always taking their special interests, taking it into the treatment. So the treatment plan included the treatment goals, of course, psychotherapy, which validation and acceptation is the core concepts, and the stabilization of emotional behavior is mostly done by the care staff, and it's around the clock intensive treatment because the staff is always there. The psychologist appears from 8 to 3 o'clock, and then they are not there in the weekends, so it's the staff who practice this. And then the skills training is planned in the group with the psychologist, the patient, and 2 main carers. So there are always a group of 4. They're working out the skills plan together. And we have, of course, evaluation points, and then we have the cooperation with local health and social services when the patient is discharged, and then we are emphasizing very strongly what is a diagnosis of personal borderline personality disorder. What is it? What is the prognosis? It's not something mythical. It's not like they will never they will never improve, because in Norway it's some kind of mythology about personality disorders. So we make an educational program for the local carers about that, about the diagnosis, because if you don't do that, they will not carry on the program. We have experienced that, so that's very important. So, of course, these patients have previously experienced a lot of rejection because of their very strong emotional reactions. They are often abandoned by their family members, by their parents, by their peers from school, and they have very few friends, really, this group. So they are socially very isolated. And when they come to us, they have often been in hospital or outside outpatient services for many years, and then they have experienced a lot of limit setting and correction because of their behavior, because they have often had very serious behavior problems, hurting staff, self-mutilation, breaking of items, parasuicidal behavior frequently, maybe daily. So what we are trying to provide is that giving the patient attention through the use of stabilization techniques and through the special interests. So that when the patient is acting out, we are not setting limits, we are not giving corrections, we are trying to calm down the situation and not noticing too much, not talking about why did you do this. If you are not stopping to act out, you have to go to your room, things like that. We don't do that unless they attack other patients or something like that. And of course, the patients are getting a lot of attention when not behaving with strong emotions. And we use the low expressed emotion or low arousal staff communication approach. And we tell the patient what we see. We are not correcting or limit setting, but we are saying, like, I see that you are in pain now, like simple things like that. And the psychologist is working with recognizing what kind of emotions is a problem for each patient, and working with the patients about that, learning about their own emotions. And the skill training also involve asking for help instead of acting out. But that is very difficult for these patients because they have learned this. They have learned that these strong reactions has been the only way of getting attention from people around. So we have around-the-clock intensive training, and I have one small example. A man in the 40s, he had these problems for more than 20 years. When he arrived in our department, he used a tie and tried to strangle himself and shouting, "I will be suffocated, I will die, I will die." That was his way of getting attention. And in 4 weeks, he tried intensively, he trained intensively to put away the tie, ask for help, and then the staff, they had 30 seconds to attend. So within 30 seconds, he would get help, and he could see on his watch that people were coming within 30 seconds. And within 4 weeks, this problem was solved. These are just some numbers to tell that the clinical outcome is very good for these patients. It's a little uninteresting. This guy with the tie, we had 1 year, he was attending to another study we had 1.5 years later, and I talked to him on the phone, and he said, "I don't need a tie anymore." So our plans further is to elaborate this way of working and try to transport it to other centers in Norway. And we have discussed, shall we train our staff, our psychologists, our nurses, or shall we try to translate the good manual from Brian Barrett and his colleagues? Because we have found that this way of working work not only for patients with personality disorders, but a lot of other problems, especially traumatic experience and anxiety disorders. So, that was about what I wanted to say. This is our clinic.
Hello. I just want to add a few words. I'm impressed by your efforts to adapt it to your resources you have, and that's one thing I want to stress, that there might be a manual, but it was set up for a certain setting, and you can always and should always adapt it to your setting. And what is also very important for me to say is that I always hear that people are afraid or have they say, oh, you have to have, it says therapy, so you need to be a therapist, and I have to have the title. I can't do it. I'm not a therapist, and that's not true. Everyone can work according to DBT, and the most important thing is that you approach the clients in a validating way. Marsha Linehan speaks of invalidating environments, and you just said it. Borderline. Many people working in psychiatry, if they heard borderline, they say, "Oh my God, again, and all those parasuicidal behaviors," and these patients have learned all those years growing up and being a young adult mostly that they can't cope, that they are insufficient in what they do, and they being kept, being told what to do, and that's where we have parallels to our clients with ID. There's often enough told that you're too stupid, or you can't do it, and we have to do it for you. We know it better, and so it has very much to do with empowering our clients to believe in themselves and to work with to start working on their problems instead of asking someone else to solve them, and that's validating the clients, and the now I lost it. Well, the point is also with the diagnosis, borderline personality disorder. You also said that Linehan developed it for impulsive and suicidal clients. And later that was used for borderline, since borderline clients are impulsive and often suicidal. But with clients with ID, it comes back to its origins. You can use it with impulsive behaviors, with parasuicidal behaviors, and the borderline diagnosis is not so important. Often enough, people are reluctant to give the diagnosis because also maybe the emotional development is not as far as you would expect for a personality to be an adult personality, so to speak. So, for example, child and adolescent psychiatrists often say we can't diagnose borderline personality disorder. This client is only 13, the personality is not finished yet. And it's the same with emotional development. In our experience, you can practice DBT with individuals with ID down to SEO3, at the very lowest phase of emotional development, phase 3, according to Anton Dozhin, and down to moderate intellectual disabilities. So the clients should be able to be able to vocalize some of their feelings, and but they do not have to read or write. That's important. And and again, adapted it was originally put up for an inpatient setting, the manual, but now, for example, I use it. It was developed in Berlin when I was still working in Berlin with colleagues Kaiser and Gaul and Feuerherd, and I now use it in outpatient setting, for example, and so you can adapt it to what you need it for, and we had quite positive results as well. Thank you very much.